Okay, this is part 2 of the lecture for Anticoagulation Elective for Campbell students. We have ended on clopidogrel genetic testing, and now we are going to move on to proton pump inhibitors and clopidogrel interaction. And the way this interaction came to be is that in the clinical, well, actually non-clinical trials, but in the lab, there was a drug interaction between omeprazole and clopidogrel, which translated into less bioavailability of clopidogrel in patients who received omeprazole. And so we wanted to see if that translates into the cardiovascular events or any kind of clinical effects in real life. And so the COGENT trial was randomized to test omeprazole versus placebo in patients who received clopidogrel and see if patients who got omeprazole actually had more cardiovascular events. And so this trial showed no significant difference in cardiovascular events in patients who received omeprazole versus placebo in clopidogrel users, and patients who received omeprazole also had reduction in GI events. Also, patients who are on aspirin clopidogrel most of the time need to have some kind of GI protective effects. As we saw earlier with prostaglandin inhibition, patients are at high risk for GI bleeds, and so PPIs can actually decrease recurrent ulcer bleedings, especially in patients who sometimes receive triple therapy as well. So there's a benefit of using a PPI with clopidogrel. Nevertheless, FDA warns us against this concomitant use of clopidogrel and omeprazole, and they say that separating the dose between clopidogrel and omeprazole will not reduce this interaction. And so in clinical practice, what we end up doing is just switching patients to pantoprazole because it's a safe alternative compared to omeprazole and didn't have the same interaction as omeprazole, and therefore that's what we use in patients who receive clopidogrel. Clopidogrel has great data in patients who who are non-STEMI or STEMI patients for secondary prevention. We have CURE trials, CLARITY trials, CREDO and ACUITY. Basically, in all these clinical trials, patients who had symptoms within 24 hours of onset benefited from receiving clopidogrel, had significant reductions in death, MI, and stroke, and you can see this is the same for all patient populations. Now we're going to focus on CURE study, which looked at primary endpoint of MI, stroke, cardiovascular death in patients receiving clopidogrel with aspirin, so dual antiplatelet therapy, or single antiplatelet therapy with just aspirin alone with placebo. And you can look at this Kaplan-Meier curve and see that after about a year, well, starting with just a month after, and for the duration of the trial, the clopidogrel and aspirin group had much lower incidence of the primary endpoint compared to the aspirin, which translates into the 20% relative risk reduction. But this was also at the expense of much higher incidence of bleeding. You can see that the dual antiplatelet therapy is associated with higher incidence of major, life-threatening, and minor bleeds. We also have the current trial, a current OASIS trial. And this trial is the most recent, came out in 2010. And what they looked at is patients who were undergoing a PCI and giving them a high dose or a regular dose clopidogrel load. And this is to overcome some of that patient variability that we see with clopidogrel. So in the high treatment group, we had clopidogrel 600 milligram load followed by 150 times 7 days and then 75 daily, versus our standard of therapy that used to be, which was 300 followed by 75. And all patients received either the high dose or the low dose aspirin, and see how that translated into efficacy outcomes. And so you can see that the standard dose versus double dose in patients with PCI, double dose, patients who received the 600 milligram Plavix actually had less incidence of the primary endpoint compared to patients who received the standard dose. This effect was not seen in patients who did not undergo PCI. And so now the new 2013 guidelines include 600 milligram dose in patients who are undergoing PCI based on the current trial. Also, something to remember that if you do give them a double dose of clopidogrel of 600 milligrams, these patients are also going to have higher incidence of bleeding. So patients with double dose had required more red cell transfusions than patients who received standard dose. Patients who received high dose versus low dose aspirin did not have difference in the primary endpoint or the bleeding. And so that's why the guidelines don't have the strong level recommendation for high or low dose of aspirin, but they do tend to recommend lower dose just to decrease the incidence of bleeding for the maintenance regimen. The limitations of dual antiplatelet therapy with clopidogrel is that you do have the increase of bleeding with aspirin and clopidogrel, as you saw in the CURE and current trials. You have delayed onset, so clopidogrel takes 4 to 6 hours to start working, and you only get modest level of platelet inhibition compared to prasugrel or some other newer antiplatelet therapies. You also get variable response, so pharmacogenomics and drug interactions play a role in clopidogrel. You have irreversible mechanism of action, so it takes 5 to 7 days for clopidogrel to get out of the system, delayed offset and residual clinical effects based on the pharmacogenomics. What about prasugrel? Prasugrel was studied in the Triton-TIMI 38 trial, which looked at patients who were planning a PCI. So this is important. Prasugrel was studied and has data in patients who are undergoing PCI. And compared to prasugrel 60 times 10 maintenance dosing versus clopidogrel 300 milligram loading dose, followed by 75. And so if you think back to the current trial, patients who were undergoing PCI actually did better when they received 600 double loading dose. And so this may not be the fair comparison, as you will see later on with the primary endpoint. So here's the Kaplan-Meier curve for the prasugrel versus clopidogrel. Started out, and for the duration of trial, they diverge early. And so clopidogrel had much higher incidence of cardiovascular death, MI, and stroke compared to prasugrel, which translated to less than 138 events, with prasugrel number needed to treat of 46. But at the expense of much higher incidence of bleeding. So number needed to harm is 167 with prasugrel compared to clopidogrel. So it is a strong major and non-cabbage bleed incidence increase in prasugrel. Then, if you look at the bleeding outcomes, you can see that patients bled not just in the composite endpoints, but also when you separated each endpoint, patients on prasugrel did have higher incidence of each of these categories. Specifically, if you look at cabbage-related TIMI major bleeding, you only needed to harm 10 patients with prasugrel or cause that major bleeding. So you can see that prasugrel is probably not the best agent to use in patients who may be undergoing cabbage. Based on this high incidence of bleeds, Triton-TIMI investigators decided to do subgroup analysis to see which patient population would really be a niche to use for prasugrel. And so patients with diabetes actually had wonderful outcomes. They had relative risk reduction in primary endpoint 30% with no expensive bleeding at all. Well, what about patients who shouldn't get prasugrel? And if you look at this post hoc analysis, you have hazard ratio here. Prasugrel is better on the left, clopidogrel better on the right. And so patients who had prior stroke or TIA history did worse on prasugrel. Same thing if they were older patients, greater than 75, they also did worse with prasugrel. And if they also had weight of less than 60 kilos, also did worse on prasugrel. And therefore, prasugrel should not be used in patients with prior history of stroke or TIA, greater than 75 years of age, and weight less than or equal to 60 kilos. And this is very important to remember because those are your contraindications for use. Ticagrelor. Ticagrelor was studied in the Plato trial. The Plato trial designed ticagrelor of 180 milligram loading dose, then 90 milligrams BID, versus clopidogrel. And so if the patients were naive, they received clopidogrel standard 300 milligram loading dose. But if they had clopidogrel before, they will get the 600 milligram loading dose to overcome that genetic variability. So this is more of a fair comparison to clopidogrel as the Triton-TIMI trial. And in the Plato trial, the clopidogrel group did have higher incidence of the primary endpoint. Ticagrelor did have lower incidence of primary endpoint, so it was more efficacious. It also had benefit of cardiovascular death, so you can see that the p-value was 0.001, confidence interval does not include 1, and also no expense of bleeding, so the bleeding was not statistically significant between the two groups, and so ticagrelor was not associated with higher incidence of bleeds. Although there was a significant interaction between the treatment effect and the dose of aspirin that patients received. So patients who received high dose of aspirin actually had lower efficacy rates with ticagrelor, and therefore there is a black box warning that aspirin dose should not exceed 100 milligrams a day when provided long-term with ticagrelor. So usually we just give 81 milligrams of aspirin with ticagrelor. I like this slide because it summarizes all of the clinical trials and kind of compares apples to apples here. So we have CURE trial that looked at clopidogrel, and so the primary endpoint was death from cardiovascular cause, MI, or stroke, and so the absolute risk reduction was 2.1% with number needed to treat of 48. With a Triton-Timi or prasugrel drug, the absolute risk reduction is 2.2% for the primary endpoint and the number needed to treat of 46, so pretty similar there. And then the Plato, which was ticagrelor, had a number needed to treat of 53, a little bit higher, but you also get the death from any course, a little bit mortality benefit there. And also, if you remember, the ticagrelor was the only one that was not associated with higher incidence of bleeds. So the CHEST guidelines do take into the account the new anti-ADP drugs and even recommend them over clopidogrel. So look at this. Ticagrelor is suggested over clopidogrel with grade 2B recommendation by the CHEST 2012 guidelines. And patients who are undergoing a PCI, they can get prasugrel, and this is also grade 1B recommendation. Pay attention to these comments here. These are very important points. Ticagrelor should not be used with aspirin doses above 100 due to decrease in efficacy. And prasugrel has contraindications for use in patients who are less than 60, greater than 75 years of age, and history of TIA or CVA. This slide is great because it tells us how we're progressing with our treatment of patients with acute coronary syndrome. You started out with single antiplatelet therapy with aspirin, and so the ischemic events were reduced by 22%. Then we moved on to dual antiplatelet therapy with CURE trial. We added clopidogrel to the mix and had even further decrease in ischemic events. And finally, with the new anti-ADP drugs, we have really revolutionized the way we treat patients with acute coronary syndrome and have really decreased the events of ischemic events by so much. Remember John? John was the patient who was diagnosed with STEMI, received a stent, and you're reviewing his antiplatelet therapy, and you want to know what to give him. This slide is very important. If you don't remember anything from the slide, please remember this slide from this lecture. The 2013 ACCHA's guidelines recommend for patients who are undergoing a PCI to get aspirin 325 milligram load before procedure. That's what we usually do. And then you can get aspirin maintenance dosing. Usually 81 milligrams is preferred with grade 2A recommendation. And then if they get the stent, they'll get a P2Y12 inhibitor, clopidogrel, prasugrel, ticagrelor. Look at the clopidogrel dose. So based on the current OASIS trial, we no longer recommend 300 milligrams of clopidogrel. We go with 600 milligrams for patients who are undergoing PCI. Well, what antiplatelet drugs further should we recommend for John? It used to matter what type of stent patients received and how long they'll get the maintenance dosing. Now it doesn't matter. So if they get double or drug-eluting stent or bare metal stent, they'll get a dual antiplatelet therapy for 1 year, regardless of what type of stent it is. So they get clopidogrel 75 milligrams a day, or prasugrel 10 milligrams a day, or ticagrelor 90 milligrams twice a day. Beyond 1 year, you just go with single antiplatelet therapy. So you will stop either the aspirin or the P2Y12 inhibitor. And then if you look at this bottom line here, you should not be using prasugrel with patients who have prior history of stroke or greater than 75 years of age or less than 60 kilos. Unless, of course, patients have double cheeseburgers, large fries, jumbo coffee, aspirin's really not going to, or the P2Y12 inhibitor is really not going to matter at that point. So you really have to combine the lifestyle modifications to your therapy as well. Finally, aspirin and atrial fibrillation. We have Jane. Jane's a 64-year-old female with non-valvular AFib, history of MI, bradycardia, and has a pacemaker. And what is Jane's CHATS-2 score? What do you think? What does CHATS-2 score stand for? C is the congestive heart failure, H is hypertension, H is age, or A is age greater than 75, and D is diabetes, and stroke is, or S is stroke. And so does Jane have any one of these past medical history? No, she doesn't. So her CHATS-2 score is only 0. What did the 2012 CHATS guidelines recommend for Jane? They used to recommend aspirin, but now aspirin no longer plays a role in recommendations for stroke preventions in AFib. And the reason for that is because there were numerous studies that found aspirin to be no better than placebo and actually have greater bleeding risks than some of the newer anticoagulants. If you look at the Aveiro study, which is the apixaban study, you can see here apixaban is definitely much more efficacious in reducing strokes in patients with AFib, but look at the major bleeding and intracerebral bleeding. Actually, the apixaban had even higher risks of intracerebral bleeding, but the same amount of major bleeding. So that's why the guidelines really say you should be using some of the newer anticoagulants rather than aspirin, because you'll get much higher benefit-risk ratio. And therefore, this is the 2012 CHATS guidelines that say patients who are at low risk, so CHATS-2 score of 0, should be getting no therapy. And this is grade 2B recommendation, which used to be grade 1B. It's not the best level of recommendation. Some patients may still be getting aspirin. We saw a few in clinical practice. But most of the time, if they are CHATS-2 score of 1 or more, we start giving them newer anticoagulant therapies. So it's things like apixaban, dabigatran, or Xarelto. Well, this wraps up my presentation. I hope this was helpful, and please feel free to email me with any questions at all. Thank you.